Well, welcome everybody. On behalf of many colleagues, both past and present, I'm delighted to welcome you all to the official launch of the celebrations of the 150th anniversary of the Department of Global Health and Social Medicine here at Harvard Medical School. My name is David Jones, and I'm on the faculty here and I was a student here before, and I have long been fascinated by the department and its history and its work. So it's wonderful to have you joining us all for these conversations. Now, it is clear from the many responses we have received that many people are surprised by our claim that this is our 150th anniversary. Some of you might remember that it was only in 2008 that the department took its current name, the Department of Global Health and Social Medicine. So we are now just in our 14th year of that configuration. Others might look further back. A standalone Department of Social Medicine first appeared in 1989. And the phrase itself, social medicine, first appeared in a department name back in 1971 as the Department of Preventive and Social Medicine. And so in that sense, you could say this is our 50th anniversary. And true masters of HMS lore might know that Robert Glaser was hired in 1963 as a professor of social medicine and would lead what went on to become the Brigham and Women's Hospital. But none of that gets us back to 1871, the year we are celebrating today. So it is the goal of this session to make the case for that 150-year lineage and to justify the year-long celebrations that will follow in our department. As you will see from the talks today, many of the core missions that we value, the recognition that medicine can only be understood in its social contexts, and that healthcare must engage in the lived experiences of its patients if it is to succeed, both of these ideas have very deep roots at Harvard Medical School. So this will be the first of a series of 6 events that will trace the history and work of social medicine at Harvard Medical School. Today, Scott Podolsky, a professor in the department and director of the Center for the History of Medicine at Countway Library, and Emily Harrison, a historian of medicine and now postdoctoral fellow in the Department of Epidemiology at the Harvard School of Public Health, will lead off. Both of them have done detailed work in the archives at Harvard Medical School and the School of Public Health, and they have come to understand the many braided strands that make up the tapestry that has become our department. And so I look forward to hearing the latest findings from their research. We will then turn it over to Jason Silverstein, a medical anthropologist, lecturer in the department, and a writer who has been at work on the more recent history, interviewing people involved in the department and its affiliates to understand the work that we do now. He will share a few of his key insights from his work. And then you will hear from 4 of our most esteemed colleagues, Arthur Kleinman, Mary Jo Good, Byron Good, and Alan Brandt, who will share their reflections based on their long engagement with this department. If everyone stays on schedule, though I fear they will not, we will have time for a vigorous discussion that will follow. We cannot discuss everything here. All of us are working on writing chapters of a book that will cover the history and the present work of this department in its full and fascinating detail. And the 5 events that follow this year will build on this history and provide what we hope will be a valuable opportunity both for critical self-reflection and community building. And so with that as an introduction, I'll turn it over to Scott Podolsky.
Thanks, David. And let's see, can you see my slides? Yes. Can you hear me? Great. So thank you, David. So we can't quite claim Virchow, but if I had to name a primary originator at HMS of a social medicine ethos, even before the advent of the department, it would be Henry Ingersoll Bowditch. Born in 1808 and devoted to the abolitionist cause, well before becoming the Jackson Professor of Clinical Medicine in 1863, Bowditch exemplified an enduring concern with social justice, whether advocating for women in medicine or threatening to resign his post at MGH in 1841 when it intended to exclude Black patients. Massachusetts instituted the nation's first state board of health in 1869, with Bowditch as its inaugural chairman. And in his 1874 address on preventive medicine and the physician of the future, Bowditch considered that the state now claimed, quote, to have the tenderest interest in the welfare of each and every one, the humblest or richest of its citizens, using its, quote, moral power and material resources in aid of state or preventive medicine, unquote. It would be in this post-Civil War setting that HMS would in 1871 initiate its first professorship of hygiene, appointing Bowditch's close colleague, George Derby, who had served as a surgeon in the Union forces and had likewise been named the first secretary of the State Board of Health. By later institutional self-definition, this 1871 professorship would be regarded by HMS itself as the origins of the Department of Hygiene, alongside the advent that year of departments of dermatology, ophthalmology, and mental diseases. And here you see the 1906 volume, both online and here it is, officially produced by the school to accompany its move to the Longwood campus, where it asserts its definition of a department and makes this claim. Back to Derby, we get a sense of his thinking and likely teaching from his talk before the Boston Social Science Association on the prevention of disease. Derby chose consumption, or what we today regard as tuberculosis, as his instructive case study. And while he correlated the mortality rate for consumption with the literal soil conditions across this Commonwealth, rather than with metaphorical soil characteristics, Derby, like Bowditch, set the tone for a century and a half of inquiry and advocacy concerning the conditions under which people live and the diseases associated with such conditions. Along these lines, Derby continued, quote, fresh air by day and by night, strong and nourishing food, dry soil on which to live, sunlight and warm clothing are the means of saving many lives which would have been hopelessly lost in the preceding generation. Ventilate the schoolrooms and the workshops and the stores and the houses. Let in the sunlight and never mind the carpets. Better they should fade than the health of the family, unquote. Derby declared that while such hygienic measures might be expensive, they not only forestalled downstream expenses, but led to a healthier, more productive populace. He wasn't afraid to appeal to the self-interest of his presumably elite audience, noting that diseases and poisons among the less fortunate could easily spread to those presuming to have constructed barriers about our dwellings, and could, quote, strike down those who may be living in fancied security, unquote. But he more pointedly asked, addressing the civic-minded pride and perhaps morals of his fellow associates, quote, what would be the effect upon the annual mortality in a community like Boston if the wretched cellars and dens in which the extremely poor and improvident live could be depopulated and their occupants transferred to well-drained and lighted and ventilated buildings, unquote. Derby himself died in 1874, and for the next 35 years, hygiene would be taught at HMS by those with a public health ethos and close ties to the Boston or State Boards of Health. As we see in this map, the department's location in 1906 on the new Longwood campus is pretty much where the TMEC is today. The last professor of hygiene, Charles Harrington, died in 1908 at a time of optimism for the medical profession, not only to diagnose and cure disease, but to prevent it entirely. Among the leading optimists was Harvard president Charles Eliot. Lecturing in January of 1909 on the coming change in the medical profession, he asked, is not the function of the medical profession regarded as preventive higher, better, happier than the function of the medical and surgical profession regarded as curative? Unquote. Others rankled at Eliot's placement of prevention and cure in opposition to one another, as though one were higher in moral value than the other. As Harvard neurologist Edward Willis Taylor stated in his Shattuck lecture less than 5 months later, quote, it is unfortunate at the present time to lose sight of the vast work which lies before the well-trained physician in his dealings with the individual patient. This time-honored personal relation may by no means be given a subordinate place from the moral standpoint, whatever the utilitarian aspects of the situation may be, unquote. This would not be the last time that prevention and cure would be placed in such juxtaposition. Nevertheless, Eliot prevailed, and the faculty moved to appoint a professor and department of preventive medicine and hygiene. And we see in this slide the first of what would be many departmental name changes to come. They recruited Milton Rosenow to become the first full-time professor of preventive medicine in America. Born in 1869, Rosenow had by 1899 become the director of the United States Public Health Service's Hygienic Laboratory, the forerunner to the National Institutes of Health, and would be deemed instrumental to its development prior to his arrival at HMS in 1909. Rosenow's 1913 MGH Ether Day address on progress and problems in preventive medicine revealed his own conception of prevention as a moral activity. Once again, TB served as exemplar, with Rosenow stating, quote, tuberculosis offers another illustration which many complicating factors have made its control a sociologic and economic rather than an exclusively medical question. We can preach and teach all we want about the importance of fresh air, sunshine, good food, rest, and recreation. But until justice takes the place of charity, many of these things will remain beyond the ability of most men to purchase, unquote. He continued, quote, in this sense, the rich man can purchase health and life itself. And in this sense, tuberculosis and also infant mortality have become class diseases. Science has pointed the way. It remains for society to apply the remedy, unquote. That same year, Rosenow published his groundbreaking textbook, Preventive Medicine and Hygiene. The book would go through 6 editions by 1935 and would be considered at the time of his death in 1946, quote, a tremendous factor in the promotion of preventive medicine throughout the world, unquote. And yet, Rosenow himself noted in his 1913 Ether Day talk that, quote, each generation retells the story of past achievements in its own way, unquote. And his textbook, focusing on a broad array of approaches to prevention, holds important cautionary lessons. In the first edition of Rosenow's 1,000+ page textbook, amidst sections on air, soil, water, and sewage, and uncited by later celebrations, we find section 2 devoted to immunity, heredity, and eugenics, including a 27-page chapter on heredity and eugenics. It's unclear how much was written by Rosenow and how much by Harvard biologist William E. Castle, whom Rosenow thanked in the preface for his input on this section. But Rosenow stated on the first page of the chapter, quote, it is now perfectly evident that heredity is one of the fundamental factors in preventive medicine, which, after all, is the true sociology. It is well known to students of biology that education and environment have but a limited power to influence imperfect human protoplasm. We are interested in educating the present generation to the facts of eugenics so that future generations may have that best of all birthrights, good human protoplasm, unquote. Rosenow would reproduce, quote, statistics of defectives in the country, and he would review proposed measures for the, quote, unquote, prevention of propagation of defectives, from education, which he deemed a failure, to restrictive legislation like marriage laws, to segregation and sterilization. Admittedly, the chapter is full of caveats and cautions for those who would study heredity or implement eugenic measures. Describing the lineages of degenerate families, Rosenow posited how much of this is due to heredity and how much to environment are debatable questions. Regarding sterilization, he would assert it is a measure which contains great potential possibilities for abuse and injustice, unquote. Perhaps Rosenow felt compelled to include the chapter for the sake of completeness at a time when eugenics was clearly in its ascendancy, and even though it seemingly contradicted his own writing and teaching otherwise. And yet, the section would remain largely intact, with caveats likewise persisting for the subsequent 5 editions of the book, all the way through 1935, a sobering reminder of the context in which we think and write and act, and of the complexities of historical figures and their legacies. Preventive medicine could indeed be linked to notions of justice, but it could also be linked to, quote, whatever the utilitarian aspects of the situation may be, as Edward Willis Taylor had warned. I'll hand over now to Emily.
Scott. So Milton Rosenow, as Scott noted, established the Department of Preventive Medicine and Hygiene at Harvard Medical School in 1909. As time went on, he found the department's development stalling within the medical school. What was needed to realize the full potential of preventive medicine, he said, was not simply a department, but an entire postgraduate school devoted to it. This inclination resulted in the creation of the Harvard-MIT School for Health Officers in 1913, where Rosenow and engineering colleagues at Harvard and MIT integrated the Department of Preventive Medicine and Hygiene with departments of sanitary engineering, tropical medicine, and a division of industrial hygiene. In the school, preventive medicine was refined into one of 9 groups of courses involved in the administration of the public's health. But the teaching of medical students continued. When the Harvard MIT School reconstituted as a semi-independent branch of Harvard Medical School, now called the Harvard School of Public Health in 1922, Rosenow described the role of the department as a portal between the two schools, linking medical students to viewpoints which ordinarily are not considered in other departments of the medical school. To achieve this goal, one of the pedagogical tools he introduced was a sanitary survey. Every second-year medical student was required to investigate a particular town in detail, the state of its water supply, sewage, milk, tuberculosis rates, schools, and more. Here you can see one submitted by student Shields Warren in 1922, which was held up for years as an exemplary assignment. Even stellar work in preventive medicine continued to encounter serious challenges from the establishment, however. For example, when the Rockefeller Foundation commissioned the same Shields Warren to create a synopsis of preventive medicine, you can see that a review in the New England Journal of Medicine of Warren's work raked the project and those supporting it across the coals. The review concluded the entire book should be recast, and the detailed nature of this review is justified only to indicate the tremendous disappointment that the reader experiences in view of the auspices under which the book is published. However, disease and mortality rates were dropping dramatically in prevention programs across the country. By the mid-1930s, the American Public Health Association was projecting skyrocketing demand for manpower to staff health offices and prevention programs across the country. Medical schools generally began to accept that some form of preventive medicine was an inevitability. Yet among medical students hoping for a career of making sick people well, there was still little demonstrated interest in taking up existing offices. The perceived problem was so acute that in 1939, the APHA formally beseeched the American Association of Medical Colleges to study and remedy this lack of motivation. By this point, Rosenow had reached Harvard's then mandatory retirement age of 65, and a successor was appointed to take up the task. That successor was John Gordon. Gordon had begun his career as quarantine officer for the US Public Health Service, and in this role, he had observed that public health policies were too blunt and that prevention needed to get much more specific in order to be effective. He came to believe two things. One, that single agent explanations for disease were wildly inadequate. He preferred the philosophy of disease ecology. In disease ecology, the health of an individual was integrally related with the social and physical environment, and it was this complex relationship and not a single pathogenic agent that best explained the specific occurrence of disease. The second thing Gordon had come to believe was that clinical observations had an essential role in this more specific science of prevention. In scarlet fever, for example, he pointed out that different clinical presentations of the disease were associated with different periods and levels of infectiousness and should therefore require different quarantine periods. This idea that clinical expertise was necessary for a science of prevention inspired hope at the medical school that Gordon's vision would open new opportunities for attracting medical students into the work of prevention. Arriving at Harvard in 1938, Gordon was quickly assigned to join Walter Bauer on a medical school committee convened to study teaching in the Harvard Medical School in relation to social and environmental components in medicine. The committee's recommendation was simple: teach preventive medicine not as the full scope of public health administration, but as an interpretation of clinical practice. The goal would be framed for medical students as the amelioration of human suffering, whether it be the consequence of physical, psychological, sociologic, or economic factors. There was reason to be optimistic about the prospects of this approach. While students continued to express distaste for traditional public health and sanitation, they were increasingly interested in the relationship between social conditions and health. Perhaps some of this rising interest can be attributed to living through the Great Depression, to growing up immersed in the kinds of political, sociological discourses that were also giving rise to the New Deal. Indeed, as plans for a new preventive medicine curriculum were being set in motion in Boston, social and economic conditions were profoundly implicated in the war that was actively spreading across other continents. In 1939, Gordon was called away from his academic roles to serve in the European Theater of Operations of World War II as chief of the US Army's Preventive Medicine Division. While he was away, preventive medicine courses generally followed the plans that he had helped to set in motion, restricting their scope from the whole of public health administration to a clinical interpretation of preventive practice. In 1940, the department indicated this shift by formally dropping hygiene from its name and identifying henceforth as simply the Department of Preventive Medicine. With Gordon gone, though, there was no one on the faculty prepared to teach such courses in preventive medicine, and the dean turned to T. Duckett Jones, a clinician at Mass General Hospital who, though not formally part of the HMS department, was a close colleague of the dean in local heart disease societies. Jones's wartime course was based on a particular philosophy of social medicine that he called medical sociology. Jones's medical sociology was, he explained, about values and the medical profession in relation to society. There are fundamental values in the philosophy of medicine, he asserted, and those values implied that a physician had responsibility to society as well as to the patient. Students in Jones's course were required to perform independent research on a social, health, or welfare problem. In the course, he did not steer clear of controversy. Suggested research, for example, research topics, for example, ranged from Blue Cross and Blue Shield to the general organization of health services in a communist state, citing Henry Sigarist's work on the Soviet Union as a model. By the end of 1943, Jones reported to the dean that students had been stirred up to accept that the social structure in which we at present live in function is far from a perfect one. His vision for the scope of preventive medical work was wide. It is my hope, he said, that students will evidence attitudinal interest in helping improve the general structure of our present social organization, both social and medical. Through the war, Jones advanced the preventive medicine curriculum with a formal lecture series in medical sociology. He tried to bring a wide range of speakers into his series, inviting the head of the AMA, for example, to speak on the point of view of organized medicine, while also recruiting Ida Cannon, former chief of the MGH Social Service, to speak on some aspects of social medicine. Gordon believed that when he returned, he would pick up the department that he had intended to lead across both of the schools of medicine and public health as professor of epidemiology and preventive medicine. During Gordon's absence, however, the formal administrative bonds between HMS and HSPH were dissolved. Its resources were split between a Department of Epidemiology at HSPH and a Department of Preventive Medicine at HMS. In principle, preventive medicine was to build a curriculum addressing the tendencies of the time towards group medicine, medical insurance, and social medicine. In practice, however, the Department of Preventive Medicine emerged from the war and the institutional split in disarray. Jones would report to the dean's office in early 1947 that the department had all but vamoosed, with the future of preventive medicine teaching and research very much up in the air. Unsurprising to those who understood the insider politics of the time, an ad hoc committee on preventive medicine recommended David Rutstein for the new position of professor of preventive medicine at Harvard Medical School. A graduate of Harvard Medical School, Rutstein had previously served as chief of the Cardiac Bureau of the New York State Department of Health and deputy commissioner of the New York City Department of Health. He was actively involved in a number of medical societies, notably the American Heart Association, the American Council on Rheumatic Fever, and he was an OPSOT consultant for the WHO and the USPHS. He was a close colleague of Duckett Jones professionally, but unlike Duckett Jones, he was known to steer clear of politically controversial ideas. Under Rutstein, who would be chair from 1946 to 1969, the department would initially set out to pursue two tracks of interest. The first track followed Rutstein's interest in the development of chronic disease epidemiology, particularly as it related to the clinical care of patients. He was a force in the early development of the Framingham Heart Study, and for the first years of his tenure, it seemed that the Department of Preventive Medicine would play a large role in the path-breaking project. The second track addressed the problems of medical services in the community. As early as 1952, the Department of Preventive Medicine proposed health programs for 400 to 600 families in the West End and the North End of Boston. This was initially done to create hands-on training for medical students For the purpose, proposals read, of teaching medical students about complete medical care. Though sounding similar to the work of Duckett-Jones on the surface, Rutstein explicitly modified the department's approach to community health from medical sociology to medical economics, meaning economic questions about the assessment and allocation of medical resources, including their cost effectiveness. The reason he gave was a strategic one. Medical economics was a way of rendering social ideas into hard facts, he explained. It was a way of getting the idea of social medicine to permeate the scientific fraternity, the medical schools, and other professional medical groups down to the average citizen at the community level. This shift was perhaps best exemplified in Rutstein's revision of the sanitary survey that had long been a cornerstone of department pedagogy. With the shift in the emphasis of preventive medicine, he wrote, the usefulness of the sanitary survey has gradually diminished. The survey now being undertaken will be focused on those facilities available to communities for the assistance of the practicing physician in the care of his patients. In this new assignment, faculty presented students with 4 case studies of hypothetical patients. Students were then asked to survey a community from the point of view of a physician just beginning to practice medicine and faced with the problem of providing adequate care for these, his first 4 patients. Over the course of Rutstein's first decade with the departmental focus on health services delivery and community medicine sharpened. Boston's development into a commuter-friendly hub city had brought massive disruption to urban neighborhoods through the 1950s. Medical area expansion into these neighborhoods only exacerbated the fraught town and gown relations in Boston and Cambridge. By the late 1950s, the university was pouring new support into programs in community medicine framed as partnerships between local residents and expert academic medical services. In 1966, HMS appointed a new dean, Robert Ebert, who was already well known for the community medicine initiatives he had attempted to spearhead at Case Western just prior to his appointment. Ebert worked closely with Rutstein to develop the preventive medicine department to this end. Early in the 1960s, they brought the department into formal collaboration with the Harvard School of Public Health and other faculties through an interfaculty initiative on health and medical care. In 1967, the Department of Preventive Medicine entered a joint venture with the HSPH Department of Health Services Administration in a new Center for Community Health and Medical Care. With money from foundations and federal agencies funded through the Great Society programming, the department took on the task of formulating and testing new systems of healthcare in the metropolitan Boston communities. In a new collaboration with MIT, department members advised in the planning of a new health sciences and technology program that would bring engineering to the macro systems problems of health services. Department faculty supported community outreach projects, from neighborhood service centers to mobile satellite clinics and vans. By 1969, a university-administered prepaid hospital care service called the Harvard Community Health Plan was up and running. To conceive and carry out this flurry of initiatives, the department hired a team of individuals with experience in US healthcare policymaking, many of whom also had international health experience and were eager to apply the lessons they had learned in international health. In 1965, Leona Baumgartner accepted an appointment as visiting professor of social medicine. Former health commissioner of New York City, she had most recently served as assistant administrator of USAID and a consulting expert to the Department of Health, Education, and Welfare. Paul Denson had led research at the Health Insurance Plan of Greater New York. Economist Rashi Fine accepted a joint appointment to the Medical School and Kennedy School of Government's faculties in 1968. Fine had also contributed to the early drafts of Medicare while a senior staff member in the Kennedy administration's Council of Economic Advisors. Many of these individuals' careers had been motivated by social concerns. Having lived through war and economic depression, having endured the political oppressiveness of the McCarthy era, they had come to believe, in many cases, that the best path to a better society was through what they called stable revolution. Many had come to practice their idealism through what seemed to be pragmatic means. Some felt that the opportunity to practice a true social medicine had never actually materialized for their generation. Through the 1960s, their hopes for social medicine were reignited, often through their work with medical, dental, and public health students. In 1967, for example, students in the local chapter of the Student Health Organization found mentorship among their department faculty, linking the community health work of Tufts, Harvard, and Boston University. In 1968, Longwood area students wanting more discussion of socially important issues asked Dr. Baumgartner to help organize an open student-faculty forum on medicine and society. It ran continuously for the next 4 years, serving cheese and beer and expert talks on topics ranging from indigenous medical service to heroin use to the environmental crisis. Even in the department's idealistic endeavors, however, there were signals of the kinds of challenges that had long marked elite aspirations to improve the health of societies. Through the 1960s, for example, faculty supported medical students designing student health projects, finding sponsors for the students among their contacts in local, state, and federal health programs. The SHPs, or student health projects, included a range of initiatives. One, for example, was designed to motivate underprivileged youth across Boston to pursue health careers. Another intended to elevate the voices of Black Roxbury residents in advocacy for health services in Madison Park. A third put pressure on the New England Medical Center to work with the Asian and Latino communities of Quincy in their plans for development. A fourth worked to catalyze town involvement in designing solutions to the particular health problems of Northern New England. But the Student Health Project also included programs that set into sharp relief some of the problematic biases of the time. One of these was the sex education program targeting low-income neighborhoods. Piloted at the Columbia Point Housing Project in Dorchester in 1967, these health projects stressed the importance of the family unit, emphasizing masculine and feminine needs and differences as normative code against single motherhood. In their engagement of neighborhood residents, student workers were to discuss contraception frankly and the difficulties that arise from an unplanned pregnancy. This was the kind of student health project that drew particular heat from the Black and Brown caucus of the Student Health Organization by the summer of 1968, contributing to a more global unraveling of the health coalitions that had made earlier advances in community health programming possible. Indeed, as the election of Nixon in 1969 forecast the expiration of a number of Great Society health programs in Boston and across the country, the Department of Preventive Medicine was watching the clock run down on many of its community health initiatives. In that time of flux and unrest, the department publications emphasized the progress made through their community medicine programs over the past 2 decades. Reviewing the Center for Community Health and Medical Care in 1969, the university's annual report concluded that after 2 full years of operation, this cooperative undertaking with the HMS has made commendable progress in establishing research programs, a fellowship training program, and affiliations with community projects such as the Dimmock Community Health Center and the local organizations known as Health Careers Incorporated and Open the Doors Wider in Nursing. But the department's community health initiatives also faced criticism more pointed than ever in the chaotic and violent close of the 1960s. They had been built on the premise that medicine and the people in the profession of medicine could and should work to ameliorate the sicknesses of societies as well as individual patients. Their detractors held up the literal and figurative fires and political turmoil across the country and the city of Boston as evidence of the failure of social medicine. New challenges brought new opportunities, however. As David Rutstein announced his retirement in 1969, the Department of Preventive Medicine looked towards a new opportunity to rethink, redetermine, and realize its goals. And now I'll pass back to Scott.
Great, thanks, Emily. And I'll carry this still further to the present. So, in fact, Dean Ebert used David Rutstein's decision to step down as head of the department as an opportunity to convene a committee on the future of the Department of Preventive Medicine. And you can see from the slides from the figures who are on this, including, of course, Leon Eisenberg, Dan Fetterman, Trapkim. In an early meeting of the committee, chaired by Paul Denson, members asserted that the longstanding departmental title, Preventive Medicine, was no longer sufficient to refer to the broad scope of the department members' aspirations and indeed become an anachronism. Social medicine would be the organizing term for the committee, and as Emily noted, reflected both the societal and educational context in which it had seemingly assumed increasing relevance. As committee member Charles Lewis, then at the University of Kansas, credibly reported to his colleagues in an unpublished piece entitled "Why Social Medicine?" The societal upheaval and self-reflection of the previous decade had made it important not only to teach anatomy, pathophysiology, and diagnostics to medical students, but quote, something of the anatomy, physiology, and even pathophysiology of the medical care system of which they will soon become a part, as well as the diagnosis of systemic and subsystemic dysfunctions, unquote. And students, at least some students, remained eager for additional instruction. A psychiatrist, an HMS admissions official, Daniel Funkenstein, had documented, whereas 0% of the class of 1959 considered the delivery of care to the entire population the most important value compared to the art of medicine, competence of the physician, or research, 42% of the class of 1971 considered it so. Whereas 9% of the class of 1959 favored national health insurance, 81% of the class of 1971 did. Whereas 4% of the class of 1959 would plan to be politically active in health matters, 68% of the class of 1971 planned to do so. Activist students wrote letters to the HMS powers that be, expressing the importance of social medicine to all students. In fact, in a 1972 working paper for the Student Committee on Social Medicine, whose senior co-author would be HMS 4 Don Berwick, what Funkenstein labeled, quote, biosocial students, declared as one of the necessary teaching goals, quote, the physician should, in many cases, be politically and socially involved. Students, therefore, need to be aware of the broad structure of American medicine to have a basis for comparison with other systems. Where alleviation of a health problem requires political action, as in housing and lead poisoning, some physicians must be prepared to participate effectively in the political process, unquote. And this is like what Dave and I are teaching in January's every year the last 10, 15 years. Such an ethos reflected the thinking of certain prominent faculty as well. The Denson Committee framed its own examination of the future of the Department of Preventive Medicine by noting, quote, society's expectations of the health establishment have changed rapidly in the last 2 decades. As a major part of the establishment, medical schools, in addition to their classical tasks, are expected to be actively concerned with the rising costs of medical care, the maldistribution of health manpower, the lack of quality controls, and above all, the loss of human dignity suffered in the seeking of medical care by large numbers of the population. As such, they determined, the term preventive medicine is insufficient to describe these concerns which deal with the relationship of medicine to society as a whole. And harkening back to the prior decade, they would summarize, the challenge to the medical school today is to preserve, deepen, and broaden the student's social conscience so that his efforts as a physician will benefit not only the patients he sees, and of course this is all highly gendered as all these quotes have been, but also the population from which these patients are drawn, unquote. They proposed changing the name of the department to that of Preventive and Social Medicine, with tight links to be drawn between the department, the rest of the medical school, the School of Public Health, the teaching hospitals, government agencies, the Center for Community Health and Medical Care, departments in Cambridge, and the Harvard-MIT initiative, which had just been started, alike. It was a broad mandate at a seemingly propitious time. In 1971, the department officially became the Department of Preventive and Social Medicine. Pediatrician Julius Richmond, who had initiated Project Head Start and thereafter served as Dean of the Medical Faculty at Syracuse, would come to Harvard and serve as the inaugural chair. And yet, the subsequent decade would represent a fluid, contested era of deliberation over the nature and future of the department. Richmond would be called away as Surgeon General by the Carter administration in 1977, which is what this image is from, with Dieter Koch-Weiser chosen to serve as acting head in his place. And a number of relationships, some enduring, some emerging, came under close consideration, including the relationship between social medicine and epidemiology, between social medicine and the behavioral sciences and to psychiatry in particular, between the department and the School of Public Health, between the department and the teaching of social medicine at the HMS-affiliated hospitals, and between the department and the increasingly prominent, but still academically neglected, field of primary care, with some proposing, again, this is the 1970s, the department as a, quote, home base for primary care at the school and its affiliated hospitals. These considerations and tensions would take place amidst the decadal changing of the guard, with Daniel Tosterson succeeding Robert Ebert as dean in 1977. And by this time, two other domains of activity had come into view, further reflecting the fluidity of academic fields and categories. First, reflecting the rise of bioethics and the medical humanities. By 1978, acting chair Kochwasser, in his analysis of the department for the HMS administration, conceptually tied the medical humanities and the social sciences more tightly to social medicine and the department per se. Second, as noted earlier, the relevance of, quote, international health to the department's concerns had dated at least the 1960s efforts of Leona Baumgartner, Osler Peterson, and their colleagues. In 1971, Kochwasser had written to Dean Ebert, blurring the lines between the local and the global and stating, quote, health and disease in general cannot and should not be considered and dealt with on a local or even national level alone. Even more in preventive and social medicine, we can both contribute and learn in international settings, unquote. As he continued, quote, I've always maintained that international medicine is not a specialty and or a career. It should be concerned for the people of all specialties and in all careers. For that reason, the Department of Preventive and Social Medicine, with its broad-based interests, should also be involved on a worldwide basis to contribute to the solution of problems in other countries and to bring back from other countries experience and knowledge that we in the US do not possess, unquote. Again, sounds familiar. Kochwasser would offer such international coursework throughout the decade, continuing to lay the groundwork for growing departmental attention to international, soon to be global, health concerns. In the midst of such academic, medical, and societal developments, by 1980, Dean Tosterson set in motion a process of what was alternatively described as departmental fission or mitosis, splitting what Kochwasser had termed DPSM into a Department of Preventive Medicine and Clinical Epidemiology to be headed by Alexander Leaf, and a new Department of Social Medicine and Health Policy to be chaired by Leon Eisenberg. As the Harvard Medical Alumni Bulletin reported of Eisenberg and his department in December of 1980, quote, like most fledglings, his newborn charge has two still developing wings. One will support research and teaching in the social sciences, sociology, anthropology, economics, history, and law, among others, and the medical humanities, ethics, and literature, bringing both to bear on problems of health, illness, and medical practices, unquote. The other wing was to focus on health policy. By the end of the decade, not only would Eisenberg bring on such colleagues as Arthur Kleinman, Mary Jo Del Vecchio Good, Byron Good, and Alan Brandt, but through further fission, the department would split into the Department of Social Medicine and a separate Department of Health Policy headed by Barbara McNeil. Eisenberg's department was often flying, with shared links to its past, yet with entirely new paths of social medicine, research, teaching, and care. In fact, these old ties and new directions were likely quite evident to veterans of preventive and social medicine. In 1974, David Rutstein had submitted to Dean Ebert a definition of social medicine. As he wrote, social medicine comprises 1, the effect of social factors on health and disease, 2, the effect of health and disease on society and the social structure, 3, the use of social resources in the maintenance of health and the prevention and treatment of disease. Rutstein had thus reflected over centuries worth of evolving departmental attention, despite its shifting names and emphases to the social production and social response to disease. Leon Eisenberg, with his new mandate and new colleagues, would add increasing attention to the social meaning of disease to the department's core mission, coupled ever more tightly to a concern with social justice and health equity. Running through all this, from Bowditch and Derby through Leon, Goods, Arthur, Allen, and many others, the department had maintained an enduring focus on the essential relationship between the social and the medical. It would, of course, carry through to our own present era. I'm happy to hand off to Jason now to carry the story forward.
Thank you so much, Scott, and thank you, Emily, too. So today what I'd like to do is share not exactly a TikTok recounting of the 1980s until today. After all, we have a chance to hear from many of the key people involved in a few moments, but rather I'd like to share some of the interesting questions that are emerging from interviews that I've been conducting in the department and beyond the department. And part of my work has been to interview people both in the department, working with the department to try to vividly capture stories of social medicine. And there have been some some common points that have emerged, and I want to raise 4 of them that might help introduce this next piece of this symposium, some questions that perhaps might want to discuss or consider that have been coming out of many of these conversations I've had a chance to have. The first is this idea that not only is social medicine it's integral to medicine, but also the role of the political. Social medicine being so integral to medicine that, you know, some of our colleagues, and I'm sure many of them are here with us now, to the point where speaking with Ann Miller told me that it's hard for her to separate out what's social medicine from what is medicine to what is the healthcare that we're providing. Carol Mitnick, I think, put it really nicely when she talks about how social medicine offers a vision of health that feels more just, more equitable than perhaps what some of our neighbors offer. It's one that rejects the implicit and many times explicit way of differentially valuing human life. And I've spoken with many people in the department. No one disagrees with that, right? And what else people agree on is that as much as you might say social medicine is integral to medicine, that politics is integral to social medicine. That the reason why so many got into this work, and I've asked, you know, people, what brought you to this? And I've asked everyone, and I'll come back to this in a minute. I've asked everyone, why do you keep doing this? Why do you stay with this? Is that there's no other way to live in a world. Once you know how people are plunged into the catastrophic poverty because they're sick or die because of where they live, and you're able to do something about it, and you have this great privilege and tools and connections, you can work against all of these forces that conspire against equity. And moreover, there's this firm belief that it shouldn't just be us in this department, that there's this reassertion, or ought to be a reassertion, of social medicine is integral to the mission of this medical school and medical education. That it ought to be part of medical education as a response to the understanding that people don't always die from a failure of medical science, but a failure to deliver that medical science. Jen Fern put it very nicely, powerfully to me when she talks about how people are dying, not because we don't know how to help them, but because they were poor, because of where they were born and where they lived. That's why they're not going to get cured. So what's the point of having a Harvard Medical School and all of this medical science and technology if people who need it aren't getting it? So a constant theme here, the political nature of medicine and also of caregiving, which brings me to a second point I like to raise, and that goes back to this word delivery, and one about the department's identity as one that's uniquely concerned with delivery, right? It wasn't always like that. Right, the department's work as an academic enterprise versus engaged critics, the analytical versus the applied. This debate here, right? Jim, of course, rebrands the department as Global Health and Social Medicine, makes delivery core to the mission. The delivery of clinical medicine as central to the mission of the department. So maybe a tough question, maybe one that I'd be fascinated to hear from the people we have here today, is where is the intellectual vision here? How do you see the compatibility, the cohabitation of the department's intellectual and delivery missions? Whether perhaps the delivery or the intellectual vision, is there a sense that it's been lost? Is there a sense that maybe now most of the grants are delivery grants, not necessarily research grants? Is there a sense that there's more of an emphasis on the delivery and not enough on the intellectual? Which brings me to a third item that's running throughout all of these interviews and conversations, that what makes this department unique, of course, in its history is not only this fairly recent delivery component, but also its intellectual bridge between Cambridge and Longwood, between the medical school and the college, this deep connection between the anthropology departments and the medical school. and how that continues beyond Arthur and Byron and Mary Jo. And so, sure, I'd like to say part of the answer is my colleague Marty Aziv and me, and we're both graduates of the department who studied with Arthur and Paul and Ann and Salman, and now we teach in the department. I proudly would say that, you know, we're starting a new master's degree program here in the department, and that I'm running with Neil Baer in media medicine and health. But also, as much as I would like to say we're part of this, please say it's not just up to us to carry this legacy. And that raises this bigger question. What is the educational vision of social medicine at Harvard, across Harvard? I mean, so many of the conversations that I've had include people talking about their experiences with classes, from the culture, medicine, illness class that, you know, Paul had done before, to the course that we lovingly refer to as SW25, this reimagining global health class that has been going on forever now, and now is you know, a new gen ed course here. Clearly, there's a desire, there's some energy for a PhD in social medicine. Is that part of this? What the educational vision of social medicine is, what it ought to be here, right? That it, you know, it's not just this delivery piece to it, but there ought to be this educational research argument for what social medicine has done, what it ought to be doing. And that brings me to the last point, which kind of circles back to the first, which is one of the most powerful parts of these conversations. Yeah, why keep doing this? So here are, you know, suggestions or things coming out of these conversations about perhaps things we ought to be doing or considering as the next steps. And, you know, why keep doing this at all? The purity of principle, as Carol so nicely put it to me many times, is romantic. I believe in it. And you can hear so many people, right? We could go around from probably every single person attending this, right? Sharing these experiences, these vivid, on the ground experiences, right? And many times what people are sharing are far more pains and defeats than triumphs. And I ask everyone, why do you keep doing it? Why do you keep doing it? Especially people who could, you know, go off and, I don't know what you MDs do. You have more options than us PhDs, that's for sure. Why keep doing it? And common answers back, right? You know, is there an anger here? Of course, there has to be some anger, right? If you're conscious to the world, there should be some anger, there should be some grief. What about faith or spirituality? Is it empathy? Is this collective, collaborative work with patients? What sustains this work of social medicine? We of course have the relationship with the medical school. We have these questions about delivery versus, you know, the intellectual component, the educational vision, but also I'd love to hear from the panelists about what has sustained you all in this work. What should sustain us going forward? I'm not going to take up any more time here. I want to turn it over and hear from David Jones and the panelists here, but those are some of the themes emerging from these conversations. Thank you so much for letting me be here and share these. I'm really excited to hear what the panelists have to say.
Well, excellent. So first, I would like to thank the three of you for speaking. I thought the review that Scott and Emily has done, even though I have seen many early drafts of that, continues to fascinate me with the kind of work that they have found in the archives and the unbelievable resonances to the things that we value now. And I think Jason did a terrific job curating a wide range of interviews that he has done to pull out a series of key themes. So I'm very eager to hear the reflections of our esteemed colleagues on both what has been presented and also their own thoughts and experiences in the department. And so we will start off with Professor Arthur Clement.
Okay, well, I thought that was a terrific historical presentations. I would have liked to have heard actually more from Jason on the more recent history. So let me fill in a few things that come to my mind. First of all, Leon Eisenberg. Leon was the chair of psychiatry at the MGH. That's how he came to Harvard from Johns Hopkins. And I was one of his residents. We were particularly close. In 1980, Leon was forced out of the chairmanship of the MGH. The story there will require Scott and David and Alan to go to the MGH's archives. It had to do with the fact that Leon was perceived as not so interested in building the clinical domain and more interested in science and in social science. When he came over to social medicine, you have to realize that those of us who had worked with him before, myself, Byron, Mary Jo, others, had not had the affiliation with social medicine. I didn't think a minute about social medicine before I came back here in 1982. My connections were with psychiatry and the anthropology department. And that's how I thought of the bridge. Secondly, Dan Tosterson. We wouldn't have anything like what we have today were it not for Dan Tosterson when he was dean of Harvard Medical School. He incredibly supported an idea that even Leon was a little skeptical about. And that was what brought me back in 1982 as a full professor. My strong suggestion that we define social medicine as the social sciences in medicine, and that we build a program in anthropology, history, and sociology that would be equivalent to those departments in FAS. And I remember a meeting I had with Dan in 1984, when Dan said to me, you must become chair of the department right now, because otherwise there's a sense that you're building the medical anthropology and Leon is just letting you do that. But I know you have a vision that goes beyond that. And Leon feels you should be the chair now. And I told Dan Tosterson, I couldn't possibly be the chair. And he said, well, why? What do you mean it can't possibly be the chair? And I said, because I'm spending 1/4 of every year in China. And Dan said, what? You're spending 1/4 every year in China? He had no idea about that international side of things. But a wonderful thing happened at that time. Leon said, I'll continue chairing the department and go over the budget and the meetings. You build the intellectual side of it. Leon, who was the sharpest, smartest, most intellectually grounded person I had ever been with, and I was his, I was like his son. Leon was very conservative fiscally, very fiscally conservative. And when I came in at 1982, I asked for several positions, and Leon, I was only able to get one position, one junior position to come with me. He had, fortunately, he would have fortunately hire Alan, but I asked I asked Byron and Mary Jo if they would accept a single position. And so this is a sign of bravery on their part and deep courage. When they came to Harvard Medical School, they shared a single position. Leon was scared stiff that we wouldn't find the other side of the income stream for them. I wasn't worried for a second. I knew that Byron and Mary Jo would have a full position within a year or two. It was Dan Tosterson's commitment that as long as we would be perceived as equivalent to the anthropology department and the history department in Cambridge, that we'd be operating at that level, that that he would be satisfied. That was his point. And I think he was critical in the development, in that development. You know, the rest is kind of history. I think what I haven't heard enough of is, remember Thomas Nippardi, the great German historian, once said, the responsibility of history is to give to the past the anxiety it held when it was actually lived. And that's really what, in a sense, our panel should do, to give you a sense of the anxiety, of the uncertainty, of the incompleteness of that time. And so, what the thing about Harvard is, generally Harvard does not spend a hell of a lot of money investing in the excellent faculty it has in their programs. Generally speaking, it gives you the permission to go out, aspire for excellence, and bring things in. And so critical to the development of the department during my time that I was involved were external funding sources. For medical anthropology, Michael Crichton. I could not say enough about Michael Crichton in terms of his support of medical anthropology. For example, when Paul was splitting his time between the Brigham and the department, we were picking up half his salary, and the Brigham was half. The Brigham had a financial crisis, and I got called by the head of ID, forget who that was, one afternoon at 3 o'clock in the afternoon, and told that starting Monday at 9 o'clock in the morning, there would be no salary for Paul unless Paul agreed to spend all his time at the Brigham. And I said, well, that's ridiculous. His greatness comes out of his time spent in Haiti as well as in the United States. It was Michael Crichton, when I called him that afternoon, who found the monies to continue supporting Paul. And Michael did other things for us that, if I went over the specifics, would indicate his strong support. He in turn asked only one thing. He said, you must always go against the grain of medicine. And I tie that into what the department became, because it went against the grain of high-tech biomedicine. And I think that's an important part. The social medicine, in a sense, was a resistance to that, and was a kind of part of the arc of interference that Paul and I know a lot about. The other part I want to say here is that we developed extraordinary relations to two FAS departments, history of science and anthropology. And there was a time when I was chair of the Department of Anthropology from 2004 to 2007, when you would have been hard pressed to find where the Department of Anthropology left off and the Department of Global Health and Medicine began. And that was because of the wonderful work that Byron, Mary Jo, and others were doing, helping to build this extraordinary bridge. So a lot has to be understood about those bridges. The same with the bridge to the history of science through Alan. It was Barbara Rosencrantz and I that chaired the committee that brought Alan back to Harvard to do this fantastic work. And it's important, again, in terms of the anxiety of lived experience, to remember the things that members here actually did. Alan, for a period of time, headed our medical ethics program. As that program was developing and its leadership was changing, Leon literally began medical ethics in terms of where we had dimensions. Al and I taught the first clinical medical ethics at the Brigham, and that's a story unto itself, but a story with Gene Brownwald saying something that indicated the level of interest in medical ethics at that time across the medical school. When Gene told Alan and me, well, you can teach everything to third-year clerks on your syllabus except one thing. And that was the first thing we were going to teach, and that was informed consent. He was against informed consent. Okay. Now he changed in the course of his career, but it's important to recognize that as kind of the lived experience and the uncertainty that was taking place. So that what looks like a logical development was not a logical development at all, and was built by pieces and bits and a little of this, a little of that. through foundations. The foundations were incredibly helpful to us. If it weren't for the fact that David Hamburg, who had been the first MacArthur professor of health policy, that David went off to head the Carnegie Corporation, called me on the phone and said, I want to help you, Arthur, but China is not something we support in this area. Go to Africa. I'll send you and Joan to Africa, which he did. He sent us to Nairobi, Dar es Salaam, and to Harare in Africa. And that was out of that came $4.5 million from and more important than the $4.5 million were the wonderful people we worked with. Very high level African academics, both in the social sciences and the medical sciences. Same with Ron Daniel, whose name will probably no one recognizes here. Ron Daniel, who was the treasurer of the university. Dan Tosterson said to Ron, you help Arthur bring funds into the department. Ron said, I've got a friend who just retired from the world's largest insurance company at that time, which was AIG. And that was Buck Freeman. Buck Freeman came to Harvard. We did a show and tell. I don't know if Byron and Mary Jo remember this, in a beautiful conference table. Buck, after about 5 minutes, in a stage whisper, said to me, Arthur, it's way above my head. How much do you want? Okay. And supported things that clearly he had no understanding of. So that's the role, the entrepreneurial role that Harvard expects from its faculty. And we could then say that, there were bits and pieces growing in different ways. And also when Byron became chair, when Paul became chair, where can you get the money from? Where can you get the support? That's been part of the way the department has been built. And so one of the things that I think should come out of this is a recognition of the fact that Harvard does not spend money, big money on ideas of its faculty. It expects its faculty to go out and raise money. The fetishism of the endowment, okay, is a limit on being able to develop things from the standpoint of great ideas and great people. And so what we have to realize here is the role of the limits on the role of entrepreneurship. It has certain kinds of limits. The other thing that I would say is that I had to present the cases for Paul, Byron, and Mary Jo for promotion to tenured professorship. And I would say that in all of those cases, the committee of professors showed a willingness to understand something that they had no understanding of, because they supported the idea of a department of social medicine and its faculty. So I remember arguing, and probably Alan has had the same experience with David Jones and Scott. I remember being asked the question, well, how do you look at these books that people are doing? And I had to explain why in history and in anthropology, books were the monograph was so critically important. And it was, and the idea was accepted by guys who, when I have a drink with them, they'd always say to me, well, what in the world is social medicine? What do you guys actually do there? I think they had little idea of this. And in the global health era, as global health has become much more central to what the departments do, I think that the understanding amongst faculty has become, outside the department, has become much greater. And the last point that I want to make on this is that is the medical humanities side. So extraordinarily important here was Alan finding the monies for the Ackerman professorship that David Jones has. But also it was the fact that the department had represented not just anthropology and history, but a humanistic approach to care, illness, and delivery that was extremely important. And I think that was recognized as an important part of the mission. And I think that that's a side of social medicine where the fact that the history and anthropology are the interpretive social sciences, and in many other universities would not be in the social sciences, but would be in the humanities, that help with that connection. So an addendum to my last point. I was in a discussion yesterday with deans and FAS and faculty about the future of the humanities in relationship to engineering, science, and medicine. And in that discussion, it became clear that humanists and the deans are deeply concerned over whether the humanities will find a way of rejuvenating or a resurgence in the university. And the decision, the idea they had was that that resurgence would come through the connection of the humanities to medicine, health, environment, and other of the key problems of our time. And as I listened to this, I realized we had been doing this. We've been doing this for decades, and that now it was becoming recognized as a crucial way in which interdisciplinary collaboration would be important, not just to encouraging humanists in the future, but perhaps to the survival of the humanities. I'll stop there.
Excellent. Thank you, Mary Jo.
Mary Jo, you're mute.
You're muted. Mary Jo, you're muted.
It was a tour de force, Arthur, and covered and many of the things I was thinking about. And first of all, I want to particularly thank Scott and Emily for the amazing detail that you put together, and recognizing some of the names in the documents you were setting forth. I mean, it was, Bob Lawrence and these other people, that we worked with and we got to know as young faculty here and as grad students in places and so on. And so it was very, very moving as well to think about my history being part of their history. I think, Jason, we still need to meet to fill in on some of the questions you have. And so I'll go back to Leon. What I had written down as ways of thinking about things was both the political and social medicine. So that certainly relates to how Jason was thinking about this, but also the cultural, the interpretive, and Leon's role in bringing those two things together. The way he tried for us to study the dimensions of medicine as being taught and ways to intervene was by putting us into situations in which we were to interview many medical students. He got the Arthur Vining Davis Foundation to fund part of our salaries, Arthur. And we set out and interviewed quite a lot of the first year medical students when we first got here. He then put us on to doing interviews with the new pathway and made the medical education program and the dean pay for part of our time with the Kaiser Fund to actually look at the new pathway and what was happening at the time that they were trying to revolutionize medical education. And one of the things I would like to say about this is that he was really pushing us to not only teach, but through our research and through the interactions that we would have with students, with medical students and with others in the medical faculty, to change the way students were being taught, and to also connect with the concern for social justice and concerns about inequalities and interest internationally. His wife, Carol Eisenberg, was also involved. There was funding from Paul Dudley White, which sent Paul, Anne, and many others off to do research between their first and second year. And we were involved in helping to choose those students. Everybody actually who applied was funded, but looking at their proposals and what they were going to do abroad and encouraging people to apply. The connection, the international connection, was quite different than what I was doing at Davis when Byron and I serendipitously ended up in a medical school and a psychiatry department at the University of California at Davis. But the emphasis on the kind of medical politics and the social medicine politics that were going on that emerged in Davis was not so dissimilar to what was going on at Harvard at the time that we were here and participating in it. The ethnic identity issues came up in California. So our courses became not only courses on culture or anthropology or what are we going, but really on, how to design new ways of thinking, new ways of teaching people who were not necessarily of the same ethnicity of their patients. And it really reflects an evolving development from the community mental health movement that had gone on in the 60s and was so important. And what was really interesting about your history was the details that you gave that also were, focusing, they didn't call them ethnic clinics at the time, but the community health centers that were being developed back in the 50s. So I, was very, very useful and interesting to connect them. I know when we came, the department had a Navajo program, and that was celebrated. And it also had community van. It was associated with the department. So what was, being furthered, I think, in the department, then by Arthur and Byron and myself, with the NIMH funding, the focus on bringing in funds for training programs for physicians and for anthropologists, sometimes a few sociologists. What we're designed to really rethink the way that medicine was practiced, but through research. So it wasn't simply research. It was, yes, tied to delivery issues. The NIMH program went on for 24 years, followed by the Fogarty program for 17 years, the Carnegie program for 10 years, the Freeman program for 7 years. The Freeman, the Carnegie, the Fogarty were all international, all tied to delivery as well as research. But that's what, in part, what made the courses fun, and interesting and compelling that the students were taking at the undergraduate level. And it enhanced the work of our graduate students and also the postdoc fellows that came and spent time with us, as well as many visiting faculty from all over the world. And over again, we were combining physicians, social scientists like Paul, some of our other colleagues from around the world who combined both, and the social scientists with the conversation. And I won't go into the issue on ethics, but in great detail, but working with Alan in the program of bioethics that he had developed and directed, and with Lynn Peterson, led us to introduce a whole new program to, and particularly me more than Byron, in medical education at in Gajah. And it continues. I mean, that Gajah bioethics program actually houses the global health program and the anthropology research that goes on that is very much tied into delivery. So, you know, one of the critiques from the anthropologists who are not medical anthropologists or psychological anthropologists is, oh, you're too involved in delivery. So I think that's something to pursue. And I will stop here so that others get a time. Sorry, I talked too long.
Byron, these are all terrific comments. Nothing to apologize for.
Thank you very much. And it's been a very, very fascinating day, period of time here. I loved hearing about the history, and I think there are both continuities that run throughout and very sharp discontinuities. And it's interesting to think of the discontinuity that began with Leon's taking the position that he did. It's also interesting to think about the continuities, and Scott, you talked about the remarkable change in attitude in the direction of the political that occurred, in particular during the 60s. And Arthur and Mary Jo and I were all in Cambridge in the 60s. And I think there is a way in which the generation we're talking about is a generation that were deeply influenced. That is, of those of us who are speaking now, were deeply influenced by the 60s, and that the kind of impulse of the department as it emerged and as it has emerged was deeply influenced by the 1960s, by the politics of the 1960s. And one piece of that we might not think of because we're thinking of the Vietnam War, et cetera, but like 2 years before I came to Cambridge in 1966, I was at the University of Nigeria. That was 4 years post-independence. We are talking about also the era of new nations. We're talking about the era of the end of colonial empires and the rebuilding of medicine globally in the face of amidst post-coloniality. And that, of course, has been a great mission of Paul's. One other sort of historical note, Arthur and I met each other in 1971, and when I came back from the field, 1974 to 76, Leon funded a seminar that is worth putting. Many of you have heard this story or participated in this and know this story, but in 1975, 1976, Arthur led a seminar that was funded by, that Leon found some funds for, on global health or on something like what turned out to be medical anthropology. And I think it's very important to say that we can look historically at the evolution of the meaning of medical anthropology and the evolution of the meaning of social medicine at Harvard as being quite closely related. What was medical anthropology in a previous time was very extraordinarily different than what it became during our many years of collaboration and working together. There was something like a certain form of applied anthropology that had very little intellectual base. And I think to make it somehow a neat distinction between the intellectual base and the practice, I think is an utter mistake. I think it was precisely the building together of an intellectual program in medical anthropology and an intellectual program in social medicine, and those being deeply related to each other. I'll say another word about sort of how we came to this, but clearly Paul bringing PIH into the department is part of a complete transformation of what social medicine has meant at Harvard. And and Paul's answer has always been, we should not be about simply doing research and hoping someone will use that research to solve the great problems of the world. We should be taking on the great problems of the world and building research into that and learning by this kind of doing, and that's at the very heart of the mission of this department. And it makes it a different department than even social medicine departments elsewhere in the country, and departments of global health, what Paul calls the effector arm. So if I think back, I think of course, of a moment we came together in 1983 when Mary Jo and I arrived, and Alan and Harry Marks were there. There were about 5 or 6 of us in the department. That was it. And what came out of that as we look around at this point has been quite an extraordinary achievement. And I would say that, as everyone has said, going back to Leon as a master builder of this, and his commitment to the social sciences that Arthur has talked about, as his also a commitment to the social sciences as being basic to medicine. And his development of his going out to find funding for the MD PhD program, and his commitment to making MD PhD programs in the social sciences the equivalent of. But he has also had a remarkable commitment to a certain kind of ethics. I remember over and over Leon saying, look, we have tenure. If we're not going to speak up on issues such as, conflict of interest, who the hell is? That we should absolutely be able to speak on behalf of those very important principles. It was during that time, however, that Arthur really began to move the department in a global direction. And secondly, as Arthur and Mary Jo have both said, built much of that work on training programs and placed MD work, PhD work, master's training and in particular postdoctoral fellowship programs and global postdoctoral fellowship programs at the very heart of the mission of the department. And I think that was a visionary. When Arthur brought us here, even before we formally left Davis, what did we do? We sat down and wrote a draft of the NIMH grant. And that was very clearly part of Arthur's vision for how to go forward. Then what I would certainly say is that from the time that Paul was a student to the time that Paul finished his MD and his PhD and his training program, to the time he became a junior faculty member, he had always a vision of deep linking of medical care to the research mission, that there is no such thing as a research mission absent responsibility for engaging in services, engaging in care, and that these two are part and parcel of our responsibility in a global world. Now that carries on in directions of work that people like Jean Richardson take on issues of post-coloniality and of colonial critique. And certainly we're awash in that these days. And the whole question of how global health can and will function in a world that's increasingly non-global. And exactly how to make that work, those are the kinds of questions that I think are facing us. And they're not facing us as, why are we still doing this? They're facing us as a challenge to how do we go forward with our utter commitment to our responsibility to work in this time. In terms, Arthur, I would just say, in terms of these questions of historically looking at funding and at moments of not knowing amidst the process and only looking back, I would just say, unlike when Ron Daniel worked with you, I remember the head of the development office coming to me and saying, you know, what's this department up to? What are your goals, et cetera? And I talked with him about who we are and what we do. He said, basically, you guys should be really easy to raise money for. Shall I put you down for $30 million? And I said, absolutely. 2 months later, he came back and he said rather sheepishly, I've just talked with the dean, and given where the priorities of the medical school are at this moment, we're putting you down for 0. Now, that was a quite remarkable moment. And I had to decide, was I going to simply resign from my position at that time, et cetera. But I'm just to say that the support of the medical school has not been continuous and in the same kind of way. And there have been ups and downs in this. I think you're absolutely right in pointing to Tosterson and his support for the intellectual program, but also think over time, what has come to be the unique mission of this department in global health is one that the medical school is now supporting again in a really fantastic way. So I think I'll perhaps end that way. I'll simply say that, you know, that despite what that was happening during the short time that I was chair of the department, we were able to get new lines, and so that we could build the kind of breadth of the department that we currently have, and that Paul has gone on in really asking, and we also something like doubled or tripled the number of research grants that we had in the department during that time. But I think when I say that Paul has always said, we solve global health problems, we conduct research and carry out our intellectual mission in relationship to that, it's meant he's also built up the department in areas such as the group of fine epidemiologists that we have at this time, and rounded out the department in quite a different kind of, you know, in a collaborative direction that has also changed where this department has gone over the time. So I think that's enough for me for now. Thank you.
Excellent. Thank you, Byron. We'll turn it over to Alan. And then I think we'll be able to ask Paul if he has any reflections after Alan has spoken.
Thanks, David. I'll try to be brief, but watch the time. There are so many issues on the table. First of all, the historical account of the lineage of our department is really just remarkable. And one way of thinking about that is, oh, it's always nice to know your history. But I think that would really underestimate the threads that run through really from the 19th century to things that we're doing now. So if I have any thought about it is watching internally in some ways what happened to these departments and these people at Harvard, and then putting them in a much broader social, political, cultural context about medicine, the competition between medicine and public health, many things that went wrong during that 150 years that are still incredibly instructive to us. I joined the department right around the same time that Arthur came back as a professor, same time that Mary Jo Good and Byron Good came and brought so much in terms of their commitment to the department and to social medicine, medical anthropology. It was somewhat unusual, I think, that Leon and Barbara Rosencrantz thought, bring a historian. And I don't think it was with this internal sort of traditional celebratory notion, but one that I think has been deep-seated in the department is that if you don't understand the past, you can't understand the obstacles to health. And this has become a fundamental aspect to the department. I say it not so much to, celebrate my field. One of the things I like about my field is that we're very, cautious about what we know and how we know it. And we always think how we understand the past is going to be changing by the questions that the present asks. And historians are always working in the here and now about the past, but they're substantially influenced by the problems of the present in understanding the past, and then what the past can try to help us understand about our own dilemmas. And that's always been, my orientation. I always felt so fortunate to be in the department, because when I finished my PhD in 1982 and I came to Harvard, I could have easily found myself in a history department. And I can't say how much having the appointment at the medical school in social medicine led to my own rethinking of the role of history, how to study it, and what it means. And so there are a couple of things that haven't come up in these excellent comments already. And I think all of us in the department started certainly by the 80s, in a rethinking of what the burden of disease actually was, and where were we really failing in trying to approach the burden of disease in Boston, in the United States, but thinking globally. And it was a moment where we began to see that that burden of disease was incredibly unequal for many reasons. And when Leon wrote to me to offer me the job, which I just couldn't believe, he said, we're going to be swimming upstream. And I didn't really know what he meant at the time, but I realized it wasn't good. But what it really said is there are going to be gigantic obstacles, and they're going to be political, economic, social, they're going to be intellectual. We're working in a world of biomedicine in which the major orientation was to uncouple the problem of disease from context. And all of us were totally devoted to trying to understand disease, suffering, illness in local and much broader context, and this unequal burden of disease. And the realization that what was going on in biomedicine was not going to solve the problem of inequality, because it was about ripping patients out of context and trying to deliver what I called in my early work magic bullets. And what was so incredible was we were able to do so much for disease after a period where biomedicine had contributed next to nothing, and that was one of the historical insights, to a time in the 70s and 80s where medicine was really developing some remarkable capabilities that were delivered to very few. And so as I look at the development of the department, I've rooted very closely to patterns of disease and our ability to see them that were so fundamentally unequal and unjust. And I think that's been the motivation when Jason asked, why are we here? It's because we could bring insights from this kind of research in the social sciences, and I would say in the humanities, I'd say a little bit more about that, that could try to address that problem that was marginalized and invisible within the dominant structures of biomedicine that we actually were rooted right there in it. And we were always pushed to the margins. We were always swimming upstream. We were always resistant, as I think a number of people have said, to this narrow biomedical construction. And the things that influenced me the most were not so internal, but watching what happened with the HIV epidemic, trying to get drugs that worked when people said, you can't do it, you can't get them there. And that was the horrible irony of biomedicine, which is we can develop these things and they're fantastic, but there are a lot of people around the world we can't get them to. And this disparity in disease was profound, but it was not being addressed within biomedicine. That had to be addressed with the social, and that's the center of social medicine. And I have to say, I've lived now through, in my career, through two massive pandemics. They've shaped my thinking and my orientation to disease. And living now, the idea that in a year we have these remarkable vaccines, but only 4% of people in Africa are vaccinated now. And there's tremendous problems of delivering those vaccines, even in a rich country like the United States, where there's an oversupply of vaccine. So these are the obstacles that I think, in very different ways, from very different intellectual perspectives, all of us have been, collectively committed to. And that's been one of the great things about being in our department. There was this sense of a unity and solidarity that we could be doing many different kinds of work, but it all ultimately centered on these problems. Just, in terms of what we accomplished and what my colleagues accomplished in this period from 1980 to the present, I would really, center attention on a couple things, and they've been mentioned, but the close ties to FAS were absolutely elemental to this, because unless you could demonstrate that we were working at the edge of our own disciplines, you couldn't have the kind of interdisciplinary culture that we've tried to build in the department. The second thing I would say is the development of the MD PhD program is so elemental. And it's one of my, really significant gratifications to see the current leadership of the program. And look, I just have a PhD. I think we have a role to play. It's not that I think everyone should have an MD PhD, but the MD PhD fractured this linear biomedical notion that has just been fantastic. And, as we look at our department, obviously Paul and Jim and Becker, Megan has an MD PhD, and so many of the people, David Jones, obviously, Scott has the moral equivalent of an MD PhD, as Arthur always did have. And so it's not the degree, but it's a way of being able to think across a intellectual boundary that can be an unbelievable obstacle. So I think that's gigantic. And, I've spent this last year directing the Harvard Global Health Initiative, a kind of not a great example of institution building, but the number of people I've talked to who did the global health residency is just amazing. And the impact it's had on their lives, no matter what they're doing now, is really, incredibly significant. So I think in terms of institution building, breaking the boundaries of the disciplines, undermining the biomedical paradigm, have all been sort of central, at least to me personally, but I think that's what is the glue that has held us together and helped us to grow and articulate an approach to thinking about health and disease that's fundamentally different than would be status quo or the dominant view. So I don't know that I answered all of Jason's questions, but I hope you see how passionate I feel about this. And I have to say, I can't observe what's going on with COVID without having a sense that there is a intellectual and practical and delivery and implementation orientation that our particular department has articulated. So what is the intellectual vision of our department? I wish I could state it more clearly, but within my own mind, it's a very clear and coherent notion of what social medicine is. So thanks.
Excellent. Thank you, Alan, for those comments. I want to turn the floor over to Paul, who I suspect will have a lot to say in reflection on what we've heard today and also on his own experiences in the field.
Well, thank you, David, and I'll save some of the latter for later. But I do just want to start by thanking particularly Scott and Emily for the detail. And I think you can both see that none of us is tired of that detail and would like to hear more. I, for one, would like to hear more about 1871. But turning to the more recent perspectives that we have yet to engage in, I just want to pick up on something Alan said. Our lives have been deeply impacted by a couple of pandemics, big ones that have, marked our experience in many ways, certainly professionally, but usually personally as well. HIV and COVID. And this is a chance for me to just get something out of the way that I've said many times and that you're probably tired of hearing. The idea that there has been an overweening focus on responding to infectious disease, but a complete neglect of non-communicable diseases, I think is fundamentally false in the manner that is laid out in this discussion. Because when we're talking about prevention versus cure, we can't be talking about social medicine. We wouldn't split prevention from cure in that way, as many have argued. And yet the concerns of colonial medicine, the most significant institutional force in many parts of the world, particularly on the continent of Africa, but in large parts of Asia and Latin America, was not to respond with caregiving, back to the Arthur's important focus. It wasn't to respond with caregiving, it was to respond with disease control. And disease control, AKA prevention, is not what the afflicted asked for. I've never had that experience as a clinician. Once already infected by whatever it is, or afflicted by whatever it is, that is not the concern of the afflicted and their families. So what we're looking at is really in many of the places that we're calling our international sites, or which nowadays get called global medicine, is not some history of a lot of attention to infectious pathogens and how they affect the living, but really how to protect investments, particularly by Britain, France, and Germany, and later the United States, how to protect investments from these pathogens, not how to protect people unless they're in the labor force. Now, I'm overstating it, but only a little bit. We really do need to correct our reading, I think, as a department of, did we have, and of course, as Alan, going back to Alan's point, AIDS and COVID make this point beautifully. After the development of effective suppressive therapy for HIV, it was years before there was a movement to make that available on the most afflicted continent or in other countries. It's the same story with COVID now. Again, the big communicable pathogen of the day, but almost very little attention to the caregiving required, even to oxygen distribution, to say nothing of vaccines. So what we're contemplating is not a failure of global health, but the ongoing failure of global health, not something new, but something that we've been living with, and something that a lot of people over the last 150 years have attempted to address. Now, I do want to say, I'm very grateful to our historians, because they're giving us the story warts and all. And again, there's a lot more to hear. But, this term we hear, poor protoplasm, the term we hear today, we see it in the documents from the 30s and beyond. We hear about the improvident, we hear about imperfections, and finally degenerates. And this is in 1935. So, it's important to say, and I didn't quite dare to say it, I didn't not dare to say it, but it's important to say that all of the department chairs to date have been men, and they've been white men. And, it's an important part of our institutional reflection to ask, is this, an accident of history, or are there forces that continue to keep us from being as inclusive as not only we want, but as we must do. And I want to go back and I'm looking at the time. I want to thank Scott, particularly for laying out the public health ethos, the progressive public health ethos that underpins so many movements forward. And again, we can all look for discontinuities, but there are a lot of continuities to be noted here. And I'm really grateful. As usual, it's the historians in our midst who can underline the continuities and also identify the major discontinuities. President Elliott's juxtaposition of prevention and cure continued to hobble us, I think. And it's not largely because of what's happening in the medical faculty. This is a reification that has reached into schools of public health, into bureaucracies of all kinds, public health bureaucracies, but also other bureaucracies and across the world. So we're going to be dealing with this for some time. I do believe we have the intellectual wherewithal to deal with it, to know why prevention versus cure is a bad paradigm. But I'd really think that Alan, Scott, David, Emily, Jason too, have given us a chance to look at the intellectual underpinnings of this split, why it must be bridged, why it doesn't lead us forward toward the place we would all like to go, and also to hear about people who resisted that. I didn't really know anything at all about John Gordon. And I thank you. I mean, I'd heard the name, but I also understand why a notion of disease ecology, why a notion of rejecting very clear disciplinary borders, but also clear experiential borders, meaning those borders are rarely seen in lived experience, why that made a difference, and why focusing on a complex disease ecology opens the door for the social sciences relevant to medicine. Now, I'm not, going to get in an epistemological debate about whether or not social sciences is a good term or not. But what we do know is that anthropology, sociology, a certain kind of economics that at least nods to political economy, and especially history, have really made this a different endeavor intellectually, but also morally, and bring us to the period that we have, many of us know through our own experience. It's precisely because this ecological view was multidisciplinary and believed in multifactorial understandings of disease and disease experience that it's for these reasons, and also, if I may add, quite unusual, the insertion of clinical expertise or knowledge. And by clinical expertise, I'm not suggesting this would only be available to clinicians, to physicians or nurses. This is not true at all. We know from reading the work of Alan Brandt, and we don't have to look to the work of Scott, David, but we're just reading the work of Alan Brandt, we see the power, and have long seen the power, of bringing medical and clinical understandings to historical materials. Doesn't require an MD or an RN to do that. What it requires is the kind of engagement, intellectual engagement, that have been front and center in this department in all its incarnations. And another way of putting this, is that we're adopting a biosocial view. And whether or not we stick with that term or any other, in a way we went for that because it was a less clumsy term than some of the others circulating. But basically the notion that we're not going to pit prevention against care, we're not going to pit physiological processes against social ones. We know that these come together in the human body, but also in human families. And again, just looking around at the professoriate here, the performer chairs, these are people who are making substantive contribution in this domain and laying it out. I will add one personal thing, as we have done, and that is to say that in 2006 and 7, when Jim Kim was still at the World Health Organization, or right around there, Byron and I got together, and many others, but particularly Byron, who was chair at the time, to ask how could we bring Jim back, and what would be, the guidelines in a way of what would he wanted to come back, as you all know, and one of those was, could we reconfigure the department to acknowledge its concerns with the broader world, its understanding that the social doesn't just occur in Brookline or Longwood or the state of Massachusetts or Northern New England or whatever term, and also to capture the growing enthusiasm, which was already by then spreading across American universities and probably European ones. I don't know very much about European universities, how to capture that growing enthusiasm for global health and how to get our attention not trained on, but continue to train our attention on delivery challenges. Because just as when people who are afflicted by a pandemic are move into a category where they're looking for care or comfort or cure, so too did we know that many of our, in fact, all of our faculty, including those who worked rather strictly in the disciplines of social sciences relevant to medicine, also were concerned again and again with caregiving, and responding to real, as Alan said so beautifully, real disparities in the distribution of disease. So again, I see the continuities, and I think that our main parent category, and I'll finish up here, has been not a specific discipline, but social medicine, which is an admirably capacious category because it allows us to fit in, whether we're medical anthropologists, medical sociologists, surgeons, people studying epidemiology, biostats, there's room for everyone there. And it remains a fairly safe rubric. Now, we can't say eugenics aside, and we're not saying eugenics aside. We're acknowledging that, as with many disciplines, certainly those who've gone through that tumultuous late 19th and early 20th centuries, we're going to run into problems like that. But I think most of us can still feel confident that there are many ways to have safeguards. We need more of them, right? But that this has been fundamentally a progressive mission, meaning the progress in question is towards a future with less unnecessary suffering and disease. I will just add in closing that I was lucky enough to interview here in 1983, to meet Arthur, and Byron and Mary Jo too were just coming on board, and to start in 1984 at Harvard Medical School. And that means that Alan was here. We quickly became close friends. He was a postdoc, but so were Rashi, so was Julie Richmond, so was Dieter, Leon, Arthur, and as I said, Byron and Mary Jo, and Dan Tosterson. So, even, and I would like to say something about Dieter because he was a significant influence on me, on Jim, on many others, probably Anne as well. And he pointed out that the notion of international medicine was kind of ridiculous, that it was medicine and social medicine, and that we should turn our attention to these really staggering disparities of risk, which were also growing, even as medicine made very significant improvements. And as Mary Jo pointed out in her discussion, it was not really a question, and this gets back to something Jason raised, of turning away from social medicine and towards global health, but rather of acknowledging the interests and concerns of our trainees, our fellow faculty, the staff and employees of the department, and the people coming in, whether through Freeman, Fogarty, or Carnegie fellowships, who of course were very attentive to the kind of suffering that they'd seen very often as health professionals. And that diminished in no way their interest in social medicine as we continued to grow ours in delivery and addressing the problems with increasingly potent tools. So I think, we have, thanks to our historians especially, a very rich vein of discussion to move us forward over the years. I will just like to say that George Daly, since we're talking a lot about deans, was of course listening to this and referred in his text to me, he couldn't get a text through here, that he was just enchanted to learn more about the history, in his words, of our fabled department. And when we make those fables into real lessons about how we can use the massive power of biomedicine and social medicine to lessen suffering, I think we'll all feel that we're continuing on a path that was laid down a long time ago, which continues to afford us really exciting vistas, but also new problems. And as we grow our department, new colleagues, new students, and new staff and friends. So again, this has been a very rich discussion and the opposite of a detour. And I look forward to continue it and have special debt to our historians. Thank you.
Well, thank you, Paul, and also to Alan and Mary Jo and Byron and Arthur for their comments and reflections on the work of Jason and Emily and Scott. As I had said at the outset of this session, this is just the start of the conversation. This is the first of 6 sessions that will take place over the year. The conversations will hopefully continue. We have some excellent questions in the Q&A that we won't be able to address now, but we'll certainly shape our work as we continue these conversations going forward. The next event in this series will be on October 20th, the Arc of Social Medicine from Context to Practice. And then on December 8th will be the third of our fall series, thinking about pandemics in the 21st century, a biosocial understanding, and that will pick up very much on the comments that you heard from many of our faculty this afternoon about the complexity of the two infectious epidemics we have faced, as well as all the other kinds of epidemics and pandemics that have run in parallel. So thank you for your participation, and we look forward to seeing many of you again on October 20th. Thank you.